everybody. Welcome to In the Know with Nina. I'm your host, Dr. Nina Crowley. I'm the Director for Clinical Education and Partnerships at SECA, where we partner with healthcare professionals and clinicians to offer body composition solutions. And today I'm joined by Beverly Tchang, Associate Professor of Clinical Medicine at Weill Cornell Medicine in New York, where she specializes in endocrinology and obesity medicine. She's board-certified obesity medicine physician and a nationally recognized leader in the field. So if you're on social media, you're seeing her summaries of all things conferences and research, and I hope everybody is already or will be following you because I love your content. Thanks for joining me.
Great. Thanks for the invitation, Nina. Glad to be here.
Yeah. So I wanted to bring you on today, especially because I know you've been a voice in bridging obesity care with other specialties. And this time we're talking about cardiology. So there was a recent paper that came out, the 2025 American College of Cardiology Concise Clinical Guidance on Medical Weight Management for Cardiovascular Health. It's a mouthful, but it's a really neat paper kind of in this space. I know we're talking a lot these days about obesity care and sort of how other specialties are getting involved and how we're really framing obesity care as not just obesity care, but treatment for some of the other chronic diseases. And so in the cardiology world, I think it's a really interesting space. I haven't dove in too much to this area yet. And so I thought you could help kind of bring some light to that.
Sure, absolutely. I can give a little bit of background too, because I'm an endocrinologist, and the obesity space, I think people have figured out, has been a little fringe up until very recently. I think in the past, really it's been popular, I would say, in the past 5 years. And I've been practicing for longer, much longer than that. And my mentors and colleagues at the Weight Control Center at Cornell have been doing the obesity thing for like 30 years. So this is something that we've been into for a long time, but it's not a recognized specialty in any way. Like no one owns it. There's no doctor that you can go to, whether it's an endocrinologist or a primary care doctor or your OBGYN who only that specialty owns it. And I think that's because everyone sees people with obesity. So it crosses a lot of state lines, so to speak.
It does.
As far as people who would show up to the clinic and people who would be the ones taking care of patients. The cardiology community, interestingly enough, they're much older, they're more established. I'd like to say that they think the heart is the center of everything. So everything's cardiometabolic, et cetera, et cetera. I've had a lot of fantastic conversations with the cardiology community online, actually. They are a fantastic community that engages with society on the digital level, like the new digital town hall, so to speak. They're on the LinkedIn platforms, they're on X, they're on social media, and they're really good at getting their message out. And that's kind of where I started interfacing with them and realizing that actually there's a space in the cardiology community that doesn't think of obesity as a disease. And it's a place where people are starting to realize so many other organs connect, right? Now they have this term cardiometabolic renal kidney syndrome. Sorry, I said kidney twice. Cardio-kidney metabolic syndrome. I think CKM is what was coined, recognizing that obesity is a huge manifestation and root cause of these downstream consequences that are heart specific, whether it's heart attacks, heart failure, or atrial fibrillation and other heart arrhythmias.
Interesting. So this landed you on their kind of that writing committee for this paper. And so can you talk me through that a little? Why did they think it was time to put this out? What really is the gap that it was trying to fill?
Yeah. So it's funny because as I went through the process with them, I was a little confused as to what do you mean you need a practice guideline on obesity? You mean, because we have the American Heart Association, ACC, TOS guidelines from 2013, obesity. We have pharmacotherapy guidelines from the Endocrine Society, but they were crucially identifying a space in their community where people just weren't treating obesity as a disease. It was maybe something just to talk about with respect to lifestyle changes, but we didn't know, cardiologists weren't comfortable yet with escalating intervention after that, right?
Okay.
It's more salient to think of blood pressure as something that you might treat first with a low salt diet. And it's almost second nature for us doctors to then say, if that's not working, let's add an antihypertensive medication. Or if you come into my clinic and you have really high blood pressure, then we're going to do both at the same time. We're going to talk about the low salt diet and exercise and all the lifestyle pieces, and we're going to start a medication. But that type of framework wasn't hitting home for cardiologists for obesity. It was a lot of obesity is this lifestyle problem. Our tools that we have right now are just, better diet, a low processed diet, as well as lots of physical activity. But, we're wondering here, there's this whole class of GLP-1s. What's that about? And I think cardiologists were really clamoring for more information, for official guidance from the expert societies on where do these GLP-1s fit in? Is this a cardiology medication? Is this something that cardiologists should be referring to endocrinologists for because it's originally a diabetes medication? Like, who owns this space?
Mm.
And as part of those conversations with the American College of Cardiology, and cardiologists, even not within that professional society, you realize that everyone wants to own it a little bit because all of our patients are coming in and asking, is this something that is appropriate for me?
Yeah. So I know in the paper there is a nice kind of strong call out, I would say, for multidisciplinary care. Is that a big feature of their kind of framework prior to this? And how does that seem to fit in?
Yeah, I think they're realizing or recognizing that obesity, because it touches so many organ systems, right? That you need a very, very strong primary care doctor and or a strongly connected multidisciplinary system. So, for example, if I start a GLP-1 for weight management, I should know how their blood pressure medication might change. When we lose 10% of our weight, our blood pressure typically improves. We see this with all of the clinical trials. And maybe that means we need to reduce our blood pressure medications. And I've published on this as well, actually, doing a post hoc secondary analysis of how antihypertensive medications change
Mm.
with semaglutide over 1 year. And what we find is we have about your chance of coming off of a medication, off of the antihypertensive, doubles when you're losing that 15% with semaglutide. So knowing how other medications might change, how dietary recommendations might change within the context of the medical management of obesity is part of the messaging that we wanted cardiologists to understand too.
Interesting too, because in my history in the bariatric surgery space, that was always a kind of a back and forth of when people were able to come off antihypertensive quite quick after surgery. And so, who's owning that? Who's managing that? So I think that's been in the background, right? For
Yeah.
the smaller population who surgery was an option for, but now obviously a much greater portion of the population will be on medication.
And I'll say this, that if you're an obesity provider looking at the guidelines, not much of it is going to feel new to you. Probably nothing is going to feel new. um, but if you're a cardiologist looking at the guidelines, I think there's a lot of new learning points there.
Mm.
Some of them just reinforces what we know, right? Like obesity, the diagnosis of obesity should go beyond BMI. That there are ethnic specific cutoffs for BMI that we've recognized forever and yet have trouble implementing in real life clinical practice. And also that there are multiple ways to diagnose obesity through other anthropometric measures. And so we kind of breathe life back into the waist circumference, which has existed forever, but we're kind of reconfiguring that as not just the waist to hip ratio, but also the waist to height ratio is a metric to measure. And now in the age of technology, of course, body fat composition is something everyone wants to know more about. Want to know about it in relation to the rest of the body, of course, but also in relation to our skeletal muscle mass and the functional components that go along with that. And so the guidelines or the guidance, the expert consensus statement is technically what it's called. The clinical practice guidance really goes through how a clinician would think about that approach. So diagnosing obesity, setting up your practice to make it comfortable and welcoming to patients with obesity, being very mindful of internalized and externalized weight stigma and weight bias, diagnosing it, assessing it, staging it, and then thinking about the breadth of options for management. Because of the GLP-1s, we're really in an era now of what can pharmacotherapy do? So the guidance is really around, we've colloquially called them the GLP-1s, but really the new term is NUSH, or nutrient stimulated hormone therapies. So that encompasses medications that are just GLP-1 receptor agonists, like liraglutide and semaglutide, and it encompasses your dual GLP-1 and GIP receptor agonist, tirzepatide. So it really acknowledges the breadth of pharmacologic tools that we have to treat obesity and acknowledging the cardiometabolic benefits, because we know that it's helping in heart failure and preserved ejection fraction, in chronic kidney disease, in type 2 diabetes, and in the whole gamut of metabolic issues.
Well worded. That you hit that right on the head. I was going to say too, I really, I think that framework of thinking about these medications as first line options, but not just for weight loss, but for reducing those cardiovascular events. And so, you can tell that it's hard to, how do you frame that if there's a faction who don't really consider obesity as a disease? This conversation comes up all the time. And I also will say I definitely could tell by reading them that there was someone on the inside. Now I know it was you advocating for the weight stigma and bias and the comfortable space and environment, because that came out really clear. And I think that's really important, that it's almost like every group wants to have their own statement because it's, from their voice into their people. But it is really nice when they can collaborate in the space, taking from the group that has been treating it, like you said, for 30 plus years.
And that's exactly what we hope for, that for people who are experts in the obesity space, they read these guidances and they feel like, yeah, this is totally aligned with what we're doing. And so we do want that consensus. For cardiologists, they're going to feel very comfortable because we still have all the tables with the named studies and all of the references and the clinical trials and that very strong evidence base that cardiologists love to have at their fingertips to cite. We have tables referencing your Sustain 6 trial and the Select trial and the Summit heart failure trial. And we have call outs to the results, to what we're excited for in terms of Surmount MMO, and the recently top line reported Surpass CVOT studies. So I think the fact that it's very strongly rooted in cardiology evidence base will make it also more digestible for cardiologists. And I draw a lot of parallels to the SGLT2 inhibitors, actually, because that was a class of medications, empagliflozin, dapagliflozin, that we as endocrinologists owned for a while to treat type 2 diabetes. And then we started discovering that, oh, this was beneficial for heart failure. This was beneficial for kidney disease. Now it's really considered a cardiology medication, along with a diabetes medication and a kidney medication. So I think we're seeing the same type of transition now, where these GLP-1s, or these NUSH therapies, are being owned by every specialty.
That's a really good point. And I think a lot of times you do need these kind of metaphors to, remind people this is like this, even though it's for, the disease of obesity, which is a, tougher one for people to wrap their causality and all of that. There's still a lot of bias even amongst healthcare providers in that area. It's good to remind them this is like how that was to begin with. I think that's really great. So talk a little bit about, indications for, I know semaglutide being indicated for cardiovascular events. And so how does that we frame that in this community? Is this something do they all know about it? Are they comfortable prescribing? Are they, we talked about the multidisciplinary care. Are they operating in that kind of framework? And where do we go with sort of some of the education around that? We don't want more people just getting medication without all the wraparound care that's needed for long-term success.
Yeah, I think that crucially, the SELECT trial demonstrating that 20% risk in 3-point MACE in people with just obesity, not type 2 diabetes, was really the tipping point for cardiologists to pay attention and be like, "Oh, this isn't a diabetes medication, not just endocrinologists are using it. Should this really be something we're prescribing along with our whole heart cocktail, right? ACE inhibitor, beta blocker, statin, SGLT2 inhibitor, GLP-1. Is this something that should be part of our armamentarium?" And I think what we're finding time and time again is that the answer is yes, especially in the realm of heart failure and all of the data that's emerging around, especially preserved ejection fraction heart failure. I think that the cardiologists aren't yet as familiar with the intensity or the comprehensiveness that obesity care typically warrants. I think that they're used to very comprehensive cardiac care, right? Cardiac rehab, for example, is standard for them. Identifying individuals or identifying actually everyone really to who would benefit from a dietitian visit to discuss the Mediterranean diet is just normal standard of care for them as well. And so I would very much draw that analogy to obesity care. That it shouldn't feel that as foreign to cardiologists because in a way they've been doing this all along. They've been talking about physical activity for heart health. They've been talking about the Mediterranean diet, fruits, vegetables, reducing ultra processed foods as part of a cardiac focused management plan. So obesity care is really very similar. It's probably the same thing, actually. I think the only difference is that we have a metric of weight that we follow, which is not the whole story by any means, but it's just one of the measures that we do, that we look at. And when we look at these medications of semaglutide, especially because that has the cardiovascular indication, when we look at how it's being implemented, it's being done in the same way that cardiologists are doing your statin and your beta blocker and everything else.
Hmm.
Dear patient, we start this medication. It doesn't mean you don't exercise or you eat a high fat diet. It means that we're doing this medication as part of your heart cocktail. And we talk about what physical activity is reasonable to start with. And we have you see a registered dietitian nutritionist talk about the Mediterranean diet, or it doesn't have to be a named diet. It just means what can we do to optimize your current nutrition plan. So I'm hoping that cardiologists find that this GLP-1 addition or the NUSH addition is actually fits very easily into what their current practice already is.
Yeah, it sounds like it. I like that a lot, and it's just part of the heart cocktail. So I like that. And yeah, I know we talked a little bit about the body composition tie-in. I do feel like, kind of like the Lancet report that came out earlier this year, where we're talking about beyond BMI. For me, it's been very interesting hearing how many providers are saying beyond BMI, but then not actually, kind of doing that as an outcome measure, right? We're still just getting a weight in clinic after we're finally, the words are coming, right? More than just weight, but then just doing weight. And so I think, getting people to do waist circumference is a challenge. That's a metric that can be hard if people are not doing it consistently and doing training amongst all their providers. But, the waist to height ratio, of course, now being a little bit more of a anthropometric measure folks are doing. And of course, I like to see sort of that call out for let's look at the adiposity and look at where that is. I think in cardiology specifically, we're wanting to look at that visceral adipose tissue and how can we do that in a way that is, both able to be done in a clinical sense, but also, something that's a little bit more than a calculated number that's not as precise at getting to that measurement. For me, I'm excited to see body composition assessment being, more in this area, just, along with some of the others. But do you see challenges for them? Like how do we make that easier? How do we have those conversations? I mean,
You know what's so funny, Nina? I think everyone who goes out there to say implementing a waist circumference is easy. All you need is a tape measure. I don't think those people work in clinics.
I think you're
Because
right.
it's not. We are a comprehensive weight control center, like tertiary care. I'd like to think top of the class. We're still trying to get a waist circumference implemented. And it's
Yeah.
because of that human element, right? You're adding an extra 1 minute, and that matters. That matters in a 20-minute visit.
Yeah.
Someone needs to come in, they're checking in, we're triaging them, we're asking our medical assistants to change their workflow. There's a user reliability to it or interreliability, lack thereof, perhaps, lack thereof, and user interreliability. If we want to be really precise, we should be asking our patients to disrobe and wear a gown. Otherwise, we're measuring a waist circumference over clothes. Some practices do that as part of standard. Some practices don't do it because it may be stigmatizing.
Right.
Maybe patients don't want to disrobe because that's not what they expected at a visit, or we just have limited time. Or what may even be worse is some practices aren't prepared for that, right? If they don't have extra large gowns and they're asking their patients to become more vulnerable without those safety mechanisms in place.
Good
So
point.
there's actually a lot of challenges to implementing a simple waist circumference. And I actually think, especially nowadays in the age of technology, it's easier to have a body composition machine that you put them on, you push a button, and then they give you all the information that you need. Or in my case, previously we would just put in an order, type in an order in a computer, and the patient has a totally separate visit somewhere else at like a different facility, at our radiology department, for example, where they would get a DEXA, for example. And that is actually easier to implement in our workflow than it is to train our medical assistants to do a waist circumference for every single person as part of triage. Because of the human element, I think.
Yeah, and it's tough as you have patients who are of, in larger bodies to get a consistent measurement. It's can be an uncomfortable conversation for both, for the person doing the measurement and the person being measured.
And I
Yeah.
will mention that when in 2011, the American Heart Association published a scientific statement on adiposity measures. And in it, it acknowledged 8 different ways to measure waist circumference. 8 published ways to measure waist circumference. Even today, I think we've narrowed it down to 2. Like we as a professional society, professional like medical community, we've got it down to like 2 main ways to measure waist circumference. But the fact that we still have 2 different ones that can give you totally different waist to height ratios, waist to hip ratios,
Sure.
speaks to a problem with universality and implementation. So I actually think it's going to be better for us if we don't implement waist circumferences and we're just doing body composition analyses, ensuring that the protocols are standardized, right? People come in fasting or what have you, because the hydration status can affect some of those measurements, then that actually gives us better reliability and a way to more precisely implement it across different spaces. I guess the one call out, of course, is that I work in New York City in a highly affluent area. We are well resourced, so to speak. And so, in places where they don't have the resources to purchase a body composition analyzer, it's like, what do we have
Mm.
for our options? And I would say that there are actually pretty good apps out there that patients can download for themselves and they can do a body composition analysis in the safety and comfort of their own home. That's actually been validated with some gold standards.
Yeah, the technology has gotten just better and better over the years, but I think it's very interesting, to think about something as simple as a measurement like waist circumference and how that can be difficult. And you did a well
And
said for Sika, we do have you do the waist circumference measurement because actually adding that into the formulas for visceral adipose tissue, which is validated with MRI, make it a little bit better. So at this point in time, that's still part of the protocol and the equation for us, but that does help us get to that measurement of visceral adipose tissue that is so much more helpful than some of the other measures of, outcome assessment. And especially in the group, like we said, with cardiology, I think for them, looking at that as an outcome measure of how the person's body's changing with treatment is going to be really exciting to see. So I also look forward to seeing how that changes in the individual patients, with their own changes over time. But it's encouraging to see even any of this conversation happening. Again, in bariatric surgery for years, there was not a lot of new uptake of technology or new options out there. I got into the field in 2007, and there was just we would do all of the work to remind people it was more than just about their weight change, but then we'd still be calling it, weight loss surgery, weight loss medications. And so I just think there's so much change, like you said, in the past 5 years in all of these aspects that I'm very excited to know, how things continue to evolve over the next couple of years.
yep, I'm 100% on board.
So well, thank you so much for this conversation. Actually, a lot of really good insights into, the cardiology space and on both sides, how we can help inform, their future practice and how what they're doing really helps with all of the outcomes we, are looking at as well. So I really appreciate you. And how do we stay in touch with you for For healthcare professionals, what's your favorite way to stay
Oh,
in
great
touch?
question. So definitely find me on X or LinkedIn. I also have a website, beverlychangmd.com. My last name is spelled Tchang. This is crucial because my disclosures are also on there too. And I always like to be transparent as to whom I'm advising for currently or in the past and kind of what hats I'm wearing, because I think that all colors our perspective on how we view things, right? So yeah, definitely find me on X, Bev Chang MD, or you can find me on LinkedIn.
Thank you so much, and I'm sure I'll see you at the next couple meetings,
Cool.
hopefully.
See you soon.
All right. Bye.